Now we have Dr. Rajesh. Okay, so this our industry is bombarded with lots of anti-VEGF, and you can see the stalls and talking to us regarding all the biosimilars and all, and they are hitting from right and left, asking us to inject and all. So Dr. Rajesh will be talking on making the right choice, like which injection is best and when to do it. Okay, over
Uh,
to you.
Thank you, Dr. Vinita and Samira, for this opportunity. I'll be talking about the making the right choice of intravitreal injection in patients with diabetic macular edema. We know that the treatment for center involving diabetic macular edema is with injections. We have a lot of injections available in the form of anti-VEGF as well as steroid injections, and more injections are in the pipeline. So as of now, what is our current understanding of diabetic macular edema and how we can use the present the available injections in the treatment of diabetic macular edema? That is what I'm going to discuss now. So what is the pathophysiology of diabetic macular edema? So it is mainly because of hyperglycemia. We see release of inflammatory cytokines and growth factors, which lead to breakdown of the blood-retinal barrier. And what is important to understand is that it is not just VEGF that is responsible for diabetic macular edema. There are also many inflammatory mediators that are involved. So we know that we treat most of the patients, or we are with the mindset that we treat all the patients with anti-VEGF injections. But then anti-VEGF injection does not work in all the patients, because there are other mechanisms that are acting in that particular patient that he is not responding. That is the reason why he is not responding to the anti-VEGF injection. So we have to think about options other than anti-VEGF, or agents which have got more which take care of most of the inflammatory mediators also, along with VEGF, when you are treating a patient with diabetic macular edema, especially the patient is not responding to the treatment. So there have been various trials. Most of the trials, they look at the visual outcome. They actually do not look at the anatomical outcome. Most of the trials say that if you give this particular injection, you can have this good visual outcome at the end of 1 year or 2 years. So we are not actually looking at the anatomical outcome. So what has been observed in most of the trials is that the patient is not experiencing a good visual outcome at first 3 months, that they are not having an improvement in vision by at least 5 letters on ETDRS chart. These patients are likely to have poor visual outcome at the end of 1 to 3 years. Similarly, if you look at the patients who are having anatomical response, not all we might have seen, all of us might have seen that even if we, after giving repeated anti-VEGF injections, many patients, they continue to have cysts and subretinal fluid and increased thickening. And these patients who do not have a good anatomical response to the first 3 injections, these patients are again likely to have persistence of macular edema at the end of 1 to 2 years, or even at 3 years. So what has been observed is that when you look at the visual outcome and when you compare it with the anatomical outcome, it has been observed that those patients who have a persistent macular edema, they are likely to have poor visual outcome. So it is equally important, rather than just looking at the visual outcome, it is also equally important to have good anatomical outcome to have a good visual outcome. So, the most important component of the fluid that we look for in a patient with diabetic macular edema is the presence of intraretinal fluid, because the presence of intraretinal fluid, or for a persistence of the intraretinal fluid over a period of time, can lead to destruction of the connections between the photoreceptors and ganglion cells in the neuroretina. So that is why when you are not getting good response, anatomic response with few injections of anti-VEGF, we should not, most of the trials say that you give 6 injections, 7 injections at a, and then wait. It is not prudent to wait for anatomical response or improvement in vision for more than 3 injections. Most of the studies now recommend that most of us now have started giving injections, or start changing the injections or shifting to steroids after the patient does not show any response after the first 3 injections. Now let us look at a scenario where the patient is having 6/6 vision. So when a patient has got 6/6 vision, should we treat the patient or not? This was evaluated in the protocol V of DRCR.net trial, and they found that whether you observe this patient, whether you treat the patients with aflibercept, or whether you do a laser photocoagulation, the number of patients who had a 5-letter drop in vision at the end of 2 years was same. So what we can understand is that a patient who is having 6/6 vision, you can actually observe the patient. You need not give any injection to the patient unless there is a deterioration of vision. Now, should you treat a patient with 6/6 vision? Yes, there are situations where we will have to treat the patient with 6/6 vision, because if the patient is symptomatic. Some of these patients, they will be having the cyst right at the center that can impair the entire vision. The quality of vision may be affected. They can have micropsia, metamorphopsia, macropsia, etc. Then that is one situation where you have to treat the patient. Then if you're planning cataract surgery or laser, so you know that after cataract surgery, there is a release of a lot of inflammatory mediators following the surgery. So there can be a worsening of the edema following cataract surgery. So you should treat the patients even if the vision is 6/6. Some of the, see, nowadays we are doing cataract even with a good vision. So even with 6/6, you inject the patient with some intravitreal injection just before the surgery. And if you're planning panretinal photocoagulation, so after panretinal photocoagulation, there can again be worsening of the edema. So to prevent that, you can give an injection in addition to the laser. And if the patient is unlikely to be compliant, the patient, especially the patient is sick, he is not able to come to the hospital very frequently, then we have to treat the patient. Then another important OCT biomarker which says that you have to treat the patient even with 6/6 is when the patient is having subretinal fluid. Because Sharath had shown his presentation is that the most extreme form of diabetic macular edema is when you get subretinal fluid. Then anti-VEGF of choice, if we are thinking that you will, most of us treat the patient initially with anti-VEGF injections. So if the patient is having a vision better than 6/9 or up to 6/12, what is your treatment of choice? So protocol T found that if you are going to give treat these patients with either Avastin, aflibercept or ranibizumab, they are all likely to have the same visual outcome. So a patient with vision between 6/9 and 6/12, we can treat the patients with any of these injections. But if the patient's vision is less than 6/12, it was observed that during the first 1 year of the treatment, those patients who received aflibercept, they had a better visual outcome compared to ranibizumab and bevacizumab. But at the end of 2 years, the difference between the aflibercept and ranibizumab was nullified, and only those patients who were on bevacizumab, they had a poor visual outcome compared to aflibercept. In fact, there was not much of difference between aflibercept and ranibizumab. So if a patient is having a vision less than 20/40, we should be treating the patient with either aflibercept or ranibizumab based on the protocol T data. So again, if you look at the protocol T anatomical outcome, you can see that the reduction in central retinal thickness was better with aflibercept compared to bevacizumab. And it was also better with ranibizumab compared to bevacizumab. So it shows that there was not much of difference between aflibercept and ranibizumab. So around 29% of patients on aflibercept, 39% on ranibizumab, and 59% on bevacizumab had persistent diabetic macular edema at 2 years in protocol T. So probably the poor visual outcome in the bevacizumab group, that explains the poor visual outcome. The persistence of the macular edema in the bevacizumab group probably explains the the poor visual outcome in patients who received bevacizumab injection. So it just again emphasizes the factor that the resolution of macular edema or anatomical outcome is equally important to have a good visual outcome. Now we see some of the patients who present to us with this kind of picture. We see a lot of hyperreflective foci. Sharad told us about hyperreflective foci. These are very hyperreflective dots which you see in the different layers of the retina, and they do not have any back shadowing. So if you see hyperreflective foci, if you see subretinal fluid, and also they have a lot of hard exudates, then you can also think about a different line of or initiation of treatment can be done with steroids, because hyperreflective foci as well as subretinal fluid, these are considered as biomarkers of inflammation. So inflammation responds better to steroids. You can also treat the hard exudates when there are a lot of hard exudates are present. Once you take care of the dyslipidemia factor, you should also be treating this patient with steroids, because with steroids it has been shown that most of the hard exudates melt away once you start the treatment with steroids. So patient having hyperreflective foci, SRF and hard exudates, steroid may be a good option to initiate the treatment. Now the reason why we are always talking about anti-VEGF injection as the first line of treatment in diabetic macular edema is mainly because of the complication associated with the steroid injection. Because with the steroid you can have cataract, and with steroid you can also have glaucoma. But when we look at when we look at our own data in our clinical practice, we see that even if the cataract develops, once you treat the cataract, these patients are likely to have good visual outcome if their macular edema is taken care of at an early stage. So just delaying the resolution, a good anatomical by not giving steroid, even after the cataract surgery, you may not get a very good visual outcome. So if you are planning, if you expect the patient to get good visual outcome, you should be able to reduce the macular edema at an early stage. So nowadays the cataract surgery is all very fine and very refined compared to the early days. So I think that steroids should be given at an early stage and should not wait for a long time before we switch from anti-VEGF to steroids if you are planning a good visual outcome in these patients subsequent to the cataract surgery. Now, some of the patients, they can have a combination of diabetic macular edema and proliferative diabetic retinopathy. So if we give anti-VEGF injections, usually it takes care of both the components, the neovascularization as well as the macular edema. But again, when you are looking at a patient with a combination of diabetic macular edema and PDR, make sure that the patient does not have extensive neovascularization. There is a lot of neovascularization. Then by giving an anti-VEGF injection, you can actually lead to a angiofibrotic switch, which leads to extensive traction on the retina. And a patient who is having a fibrovascular or just a neovascularization along the arcade, after the injection, because of angiofibrotic switch, there can be a traction, worsening of the traction, which can lead to a traction retinal detachment involving the macula. So just because the patient is having PDR and diabetic macular edema, don't always think that you are going to treat the patient with anti-VEGF injection. You should also take into consideration the extent of neovascularization and treat the patient properly, the macular edema, with steroids, and then you do fractionated PRP to prevent a sudden angiofibrotic switch. So when to consider switching to steroids? So from what I have told you, now we know that when the reduction, there is no significant reduction in the central retinal thickness during the first 3 months, or there is not much significant improvement in vision during the first three months. If the patient cannot afford a stronger anti-VEGF injection, then we should think about switching to steroids. And at a later stage, if during the second year of the treatment, if the patient is still on anti-VEGF injection, and during the second year the patient has received more than 6 anti-VEGF injections, that means again the patient requires treatment with steroids. And there are certain situations where we use steroids as the first line, especially a recent MI, CVA, advanced nephropathy, and before cataract surgery, as well as in vitrectomized eyes. In vitrectomized eye, the steroid of choice will be a dexamethasone implant, which stays in the vitreous cavity for a longer time. Now we have more stronger anti-VEGF injections now available. The need for stronger anti-VEGF injection is first again to have much better anatomical outcome. More than that, stronger anti-VEGF injections, they helps us to reduce the number of visits the patient requires for the treatment of diabetic macular edema. Because if you look at brolucizumab as well as faricimab, it has been observed that these patients who receive the treatment with brolucizumab, almost 50% of the patients, they can be maintained on 3 monthly injections. So one reason why the treatment for diabetic macular edema fails in most of the patients is the requirement for frequent injections. So if you can reduce the number of injections by having an agent which has a prolonged duration of action, then that is going to ensure a good visual outcome. So that is why we should use brolucizumab or faricimab in patients with diabetic macular edema, especially if you want to reduce the number of injections and to increase the compliance. But the problem is that these are all very expensive injections. So from the trials with faricimab, it has been observed that these patients, they achieve same visual outcome compared to aflibercept with fewer injections. Same, the number of patients who had complete absence of diabetic macular edema was again achieved with a few number of injections with faricimab compared to aflibercept. So it is even stronger than aflibercept. To summarize, diabetic macular edema is not solely driven by VEGF. You should always think about other inflammatory mediators. And if the patient is having persistent edema, after 3 injections, you should either switch to a stronger anti-VEGF or a steroid. Thank you.
Thank you, Rajesh. Any questions?
Yes, maybe you should. Most of the time, the steroids, they work for around 2.5 to 3 months. So when the patient gets a recurrence, we repeat the injection. And always see the other things like whether the patient is having glaucoma or not. Otherwise, there is no problem. Even when there is a glaucoma, if it is controlled with anti-glaucoma medications, still you can repeat the injection. and always get it evaluated by a glaucoma person to make sure that there is no already visual field defect has happened.
Just for a discussion, like suppose it's a large macular edema, like 700 microns in a phakic eye. So, will you be hesitant to inject a dex implant, or you want the patient to start with? Suppose the patient is coming with all these inflammatory markers and all, like so many inflammatory markers, and also, what will be your choice? Like, will you be going ahead? It's a
See,
phakic eye.
even in the presence of all these inflammatory markers, the first line of treatment is usually anti-VEGF injections only. But unless there is a contraindication for use of anti-VEGF injections, unless there is no contraindication, then only when there is a contraindication for anti-VEGF injection, most of the time I start with the steroid injections. But
Okay.
it is, but that is why I'm saying, because just because you think that the patient is going to develop cataract, you should know that you can give 3 injections, see whether it is working. If it's not, then immediately switch to steroids.
If given a choice, like the cost is not a factor, so which anti-VEGF will you prefer?
Uh, I will say maybe faricimab, because it has got dual mode of action. It is not just blocking the VEGF; it also has angiopoietin 2 inhibition. So angiopoietin 2 inhibition is also supposed to prevent inflammation. It's not just anti. So angiopoietin, the advantage of faricimab is that it blocks VEGF, it blocks the inflammatory mediators, and it also blocks fibrosis. That is why it is very good in CNVM patients also.